chat that again. I'm Dr. Abanulo. Thank you all for coming, for tuning in. And this topic that we're going to talk about is one that's very near and dear to my heart, and it's about bladder control and really bladder health. And then we'll also go over a few things about issues that can come up and things that we can do about it. So why do we care about bladder health? The short of the long story is that every organ in our body needs to function in order for us to really live our best life. When something is not working well, it really does impact other facets of life, right? So we have physical issues, limited participation in activities, right? I think we can imagine how that can be an outcome when our bladder doesn't work well. And that really does lead to a faster decline in health. It's been proven by multiple studies when we're not social, right? So reduced social interactions, altered travel plans. There's also a psychological piece to it. There's guilt, there's depression that happens. And I'll say that for any medical condition, when you're going through something physiologically, it can actually impact your view on life and how you approach things. And it's definitely true for pelvic floor issues. Loss of self-respect and fear of accidents. As far as intimacy, it can limit our desire and our ability to enjoy pleasure. Occupational, I can't tell you how many of my women have had to change their job because of issues that were happening in their bladder or in their pelvic floor. And then, of course, domestic issues. So this is looking at the things that we have to plan around our day, where we go, what we wear, how much money we budget for these issues, okay? So very impactful. And I always tell women who ask me, how did you get into this profession, and how did you realize that this was something that you
This is Cheyenne. We still have no audio. Is there technical difficulties? The host or Fiona?
1 second.
Does the audio need to be on my phone?
Let's try that.
Yeah. But I'm also in the meeting. So
Yeah.
I was gonna say, can you turn it on when you're later?
Okay, can you guys hear me now?
Yes.
Turn the volume down, but not the.
On yours, maybe?
I have communication with others.
Yes, Cheyenne, there are technical difficulties.
But I love you.
I know, that's why I
wish I could help you because I'm a Zoom master.
There we go.
Okay, so we're gonna get back to
It's tough.
it's a perfect size. Okay. Okay,
I think we're good.
are we good? Can you guys give us a thumbs up if you can hear in the Zoom?
Oh, fabulous.
Okay. So anytime women ask me, how did I get into this profession? I always like to tell people that 1 in 3 women in their lifetime will have an issue that impacts their pelvic floor. As far as urinary leakage, it happens so frequently, people think it's just a normal part of aging. Turns out it's not, right? And also it turns out that there are lots of things that we can do about it. So my goals for you today is to talk about what a healthy bladder looks like, signs that your bladder might need some help, urinary leakage, talking about that and the diagnosis, the different types, and then the things that we can do. Okay. So what gives me the authority? For those that haven't met me before, I was born in Nigeria, grew up in Georgia, went to tons of schooling. People always ask me, where did you train? And I'm like, where do you want me to start? But a really long journey that really very serendipitously landed me in a profession where I have a great balance of both worlds. I love my patients, but I also love to work with my hands, so I love to operate a lot. I have, I think, undiagnosed ADHD. I cannot do the same thing every day, so I love being in both clinic and in the operating room, and just really connecting to people, with people in such an intimate space. So that is the bulk of my journey, but I did do a lot of research on different surgical techniques, risks of complications with different things, as well as the history and risks associated with the use of estrogen, particularly in the vaginal floor. And so really my career has revolved and evolved in terms of how we look at the different conditions that affect us as women, particularly when it comes to bladder health. So, signs of a healthy bladder. So, for one, you don't even think about your bladder, right? I think there's some of us in here that are like, yeah, I think about my bladder all the time, right? It's all I think about. You usually can use the bathroom 7 times during the day, and you're technically supposed to sleep through the night. It's not supposed to wake you up. You can comfortably go to the restroom, maybe even take a leisurely stroll and, water your flowers on the way there. Those are signs of a healthy bladder. Exercising freely without needing any extra protection. And then there's no discomfort when using the bathroom. And so that's me alluding to bladder pain and issues that affect some of our women. And then rarely having UTIs. Our rule of thumb is you want to have less than 3 in 12 months or less than 2 within 6 months. Great question that always comes up. How do I keep up the good work? How do I maintain my healthy bladder? I always talk about Pilates and barre. That's my first and favorite. These are exercise programs you can do at home. You can join a studio. But as opposed to just kind of working your abs, these are exercise programs that actually address and engage your pelvic floor muscles, your levator muscles, your perineal body, your anal sphincter, right? Your psoas muscles. So I love those exercise programs. Lower body weight training, which I differentiate between training and strengthening or training and working out. What I always like to joke about is that most heavyweight lifters don't have stress incontinence. And that's because they are trained. Their muscles gradually reach these heavier and heavier weights. And so the same is should be true for anyone who wants to obtain and maintain that strength in your lower body. Also, lower body strengthening is wonderful for long-term balance and mobility. So we should always try to invest in that. Nutrition, the things that we're putting in our body can impact our bladder function. We talk about probiotics. I also tell my patients about D-mannose. This is for women that have recurring bladder infections. D-mannose is a natural supplement that coats the bladder. It makes it hard for bacteria to latch on and recur. Water intake. 6 to 8 cups is what we say is textbook. But honestly, some women do great with 4 cups. Some of my patients refuse to do less than 10 cups, okay? But we want to find that balance and know that we're flushing our system regularly at least once time a day. And then bladder irritants. So these are just all the wonderful things of life. The chocolate, the coffee, the caffeine, citric foods. We have an entire list that we'll give our patients as kind of a guideline, and there's often things on there that will surprise us, like sourdough bread. That's our sourdough baker. But for some women, it irritates their bladder. And then behavior, in addition to prioritizing exercise, we like to limit fluid intake. My rule of thumb is 2 to 3 hours before bedtime. You want to avoid any fluids. And as my 6-year-old pointed out, there's a lot of water in the fruit, so I don't have to drink water. So any foods that are rich in water, we want to minimize those as well. And then timing your voids is an interesting one, right? Because on one hand, mom always said, you gotta pee before you leave the house, right? But then that trains you to think that if I don't pee now, like I'm gonna have an accident. But then we have if I don't pee at this bathroom that I see right here, I'm not gonna make it to the next bathroom. And so timing our voids, ideally we wanna go 2 to 4 hours between voids. You usually go right before you go to bed, and then when you wake up, you want to be able to just casually sit on the edge of your bed and think about the day, as opposed to throwing out the sheets and running to the bathroom as soon as you can, right? That is what we hope for our women. All right. So when things go wrong, as they sometimes will, that's a line from one of my favorite poems. Here's a list, and there are things that are not even on this list, but these are issues that can occur when our bladders are not healthy. So we've got urinary leakage, frequency, urgency, and the difference between frequency is I'm going often versus urgency is I go from 0 to 100 when I stand up, when I see a bathroom, when I turn the key in the door, when I go home. That's more of an urgency. Waking up at night to go, that's nocturia, is our medical term for that. Incomplete voiding, so not emptying completely. Bladder infections or urinary infections, blood in the urine, special place in our heart for that. And I'm happy to take questions about that towards the end. We actually have a talk on that later this year. And then bladder and urethral pain, we actually have a talk on that too. So urinary leakage, there are two main types of urinary leakage that women will have. One is the coughing, sneezing, laughing leakage. The I'm gonna laugh so I cross my knees leakage, right? That is what we call stress incontinence. Basically, activities that produce sudden stress onto your pelvic floor, those are called stress leakage episodes. Urge incontinence is a little bit more tricky to identify. Urge incontinence can present as I'm going a lot, I'm waking up to go, I leak as soon as I park my car in my driveway, that's urge. Urge is also when I go from sitting to standing, I suddenly have full incontinence or I'm rushing to the bathroom. Urgency is also sometimes I go to the restroom and there's leakage and I didn't even know it happened. So these are all signs of a bladder that's hypersensitive and overactive. Got this line in here about overactive bladder, and it's really just talking about, again, the different ways in which overactivity can show up. So we went through frequency, urgency, incontinence, nocturne. I've covered those. So now that we've identified what a good bladder looks like, and I've honed in on urinary leakage, now I want to talk to you about how we evaluate for that. Here at Femme Flôr, we dive really deep. When you come in, we ask tons of questions that may seem very unrelated, but the bladder shares a very defined space, right? We've got our bladder, our uterus, if you still have one, and our bowels. And I always like to say, if there's ever a fight, the bladder is going to lose. Mm-hmm. So if you've got fibroids, enlarged uterus, adenomyosis, where the uterus is really boggy, the bladder is just going to keep emptying because it doesn't have space. Constipation, bloating, ovarian cysts, the bladder is just going to be the one to go more often because it feels it doesn't have space. And so when you meet a provider about leakage, they really need to ask all the questions. I mean, I've diagnosed things that we didn't even see coming because they came in for leakage, okay? So we want to do a thorough history. We also go through medications. There are medications that can cause leakage, such as our diuretics, our water pills. There are also some behavioral health medications that can cause leakage as well. So we go through medications and then we go into your exam. And the exam, we do a cough stress test. That's why when you guys come in and I'm like, please don't pee before I do your exam, we're trying to give you the best chance to prove that you have leakage with stress incontinence. It tells us so much information without charging a ton more money to get that answer, long story short, in all transparency. And so that's what that cough stress test is. We're looking for a prolapse. So when things come, when we have prolapse, which is where parts of the vagina is coming down to the opening or past the opening, that can pull the bladder out of place. And so anytime that bladder is displaced, there is a good chance that it's contributing to some of the urgency or leakage that you're having. We look at pelvic muscle sensation, control, and strength. I'll usually do a Q-tip test in the beginning where I'm looking for reflex. And by this point, I've already asked you questions about bladder function, pelvic floor function. I'm trying to detect if this is a neurologic problem. Okay, that's, again, a diagnosis that tends to come out of left field for some of our women. Assessing your ability to fully empty your bladder. So I mentioned earlier, incomplete voiding is another way that a bladder can be unhealthy. Sometimes my patients will say, yeah, I'm here for leakage. It's happening when I cough. It's happening when I sit to stand up. And then we do the bladder scan, that little ultrasound that I do, and your bladder is not emptying. So now we have a different picture and a different pathway for your treatment. And then we collect a urine sample, and infection, blood, stones, these are all things that can irritate the bladder and cause you to go more often. So we want to cover all of our bases here. So what can I do about this? So I'm going to cover treatments for both stress incontinence and urge incontinence. We'll start with stress incontinence. For stress incontinence, you always have options. Always have options. We have non-surgical and surgical, okay? Non-surgically, there's behavioral change, and so those are the Pilates, the bar, the lower body strengthening or training that we talk about. There's also pelvic floor physical therapy. Now, when I send you to the physical therapist for stress incontinence, my goal is that they'll help to assess the strength, teach you exercises that you can do at home on your own to further strengthen the pelvic floor. When I send you to pelvic floor PT for urge incontinence, that's a different goal. Now we're trying to retrain the bladder. You might have the best strength in the world. In fact, you might have too much strength, which can also irritate the bladder. So when you're heading out to PT, you want to be equipped with what your goals are so that you know that they're on the same page as you. And then lastly, there are pessaries. Pessaries are these silicone devices that we fit you for in clinic. If you ever come into the office, I have a little pessary museum here, and it shows just how far we've come as far as these devices. And just today I was talking with another urogynecologist about making 3D pessaries. So what they do is they give you support underneath that urethra so that when you do apply that pressure, you have kind of a reverse support there, all right, so that we decrease that leakage. Pessaries are age-old interventions, and you can wear them forever, or you can wear them when you're ready to have surgery. You don't have to, this is the same spiel, y'all, so I'm a broken record, okay? You don't have to take them out to have intercourse. Some women take them out, some women don't, and that is completely fine. Our clinic is able to support you in either way. Now surgically, and there'll be more information about these interventions on our next slide, but there are 3 surgical options that are specifically for stress incontinence. There's urethral bulking. These are injections into the urethra. Mid-urethral sling, small piece of mesh underneath the urethra, and then birch urethropexy. That's our old school technique. So that's going behind that pubic bone. I'm using sutures to stabilize the urethra, okay? And one thing I always want to have enough time to explain is that if you go into surgery with the wrong type of leakage in mind and you do a stress incontinence surgery, there is a 44% chance that you'll still have leakage because you treated the wrong type of leakage. So we want to know before we get into the operating room, before you get exposure to that anesthesia, that we're making our best informed decision. All right, so stress incontinence, going over non-surgical again, there's the behavioral modifications. I forgot to add cardio. Cardio is excellent for pelvic floor strengthening. And I always encourage, if you're gonna do exercise, which of course we want everyone to do, you wanna have a good mix and balance of these 3 things throughout the week if you can. Pelvic floor physical therapy, we keep a list of our favorite therapists. We have a talk in April with Jessica Dorrington, who she is the owner of Bethany Therapeutic Associates, and she's one of our old heads. I mean, she is, Jessica, you're not old, I'm just saying that you are. well seasoned, and just super knowledgeable. In fact, I have her book on our coffee table that she just published last month. But this is something that we talk about, is the role that pelvic floor can really play. Pelvic floor physical therapy is very new, which is similar to my field, right? My field was like, urogynecology was born in the late 80s. So if you compare that to cardiology, which was from the 1800s, we're new, we still have a lot to learn. Pelvic floor physical therapy is even newer, right? We still in Oregon have, I think, the first ever still practicing. So that just gives you an idea of how standardized, right? How gold standardized the treatment is. You have some people who maybe didn't go to training. I'm just being honest. And then you have those that who have been to training. They've been apprenticed, and and they have the skills that they need to really navigate the complexities of pelvic floor care. So obviously Jessica's site is one of those sites, but we do keep a list of our favorite places. And feel free to always call if you just want advice about where to go. They'll usually work with you for 3 months. They'll give you weekly sessions or every 2 weeks. And here we're focusing on strengthening. All right. And we talked about the pessary use. All right. Okay, so going into surgical options. I didn't say this before. If you have questions in the Zoom, we'll take them after the presentation is done. Feel free to put them in the chat if you don't want to forget about them. All right, so urethral bulking. The history of urethral bulking actually has been tumultuous, okay? We've used collagen, silicone, carbon, and what we use now is something called Bulkamid. The difference between Bulkamid and those other 3 materials is that Bulkamid is a gel. It's basically one conglomerate solution, whereas previously these were particulate matter. And the reason why that's important is we were finding that over time the particulate matter would migrate. It would get in the bladder, it would go into the tissue, it just wouldn't work. Not only would you have to redo it, but these women would get UTIs. Because now the material is sitting in the bladder and it's hard to pick it out cystoscopically. So Bulkamid, I was reluctant to bring it on because of the history, but after they came out with their 7-year study, they were able to present the material. It originated in the Netherlands, and then once it hit that 7-year study and they were able to kind of prove their case, that's when they launched it in the US. So the 7-year study basically showed that 80 to 85% of women were still as happy as they were the first day. Repeat testing showed that the material had not migrated. And so also, more importantly, there were really no complications that we could identify with urethral bulking. So I like urethral bulking as an option. It works best if you have something called intrinsic sphincter deficiency. And this is where you leak very easily. When I mentioned having that full bladder, sometimes we will leak just coming down on the exam table. That woman is a great candidate for bulking. Or if we do some bladder testing and we see that the strength of the urethra is really low, that woman qualifies. And then also if there's a lot of mobility in the urethra, if you've had an exam with me, I'll have you bear down multiple times. I'm trying to give your urethra a chance to show itself. And so if we see a lot of movement, that also is a reflection that the urethra has lost some of its integrity. So the bulking works great in that population. It's also a great option if you're just like, I don't have a lot of downtime. I got to get back to work on Monday. And so that woman may also choose to do a urethral bulking as well. Okay. So quick procedure, 80 to 85% satisfaction, very few complications. Haven't seen any yet. All right, mid-urethral sleep. I'm going to take this moment to talk about mesh because it is something that has been around forever and has plagued our women for some time. So there are 3 types of mesh that have been used historically in urogynecology. This is probably our second oldest one. It's been around for over 20 years now, maybe 20, 22, 23 years as far as a technique. This is a small piece of mesh that's placed through the vagina to sit underneath the urethra for support. I have a picture here of the 3 different types that you'll come across as you talk to different urologists or urogynecologists. I usually do the retropubic sling. Okay, that's that nice U shape underneath the urethra. We also have the mini sling. Some people will refer to that as the single incision. And then we have the transobturator sling. Okay. Now, overall, all 3 options have a very low complication rate at 2.5%. Some studies say 2, some studies say 3. I just average it out. The kind of complications that you might see are pain, erosion, bleeding, rarely infection or actual allergic reaction to the mesh. The allergic reactions are so rare that we have to report it to the registry when it happens. And with this type of mesh, worst case, we can take it all out. Okay, so that is our mid-urethral sling for leakage. The second type of mesh is called sacrocolpopexy mesh. This mesh is placed through your tummy to fix prolapse. Okay, and then it's secured to a ligament that runs in front of your sacrum. This mesh has been around since the 80s. We originally fashioned it after abdominal hernia mesh. We learned it was too heavy for the vagina, and now it's super lightweight and soft, and it carries a 2% complication risk when we keep the cervix in place. So these 2 types of mesh are exceedingly rare when it comes to lawsuits and problems and permanent problems, most importantly, okay? I offer sacrocolpopexy because worst case, I can take it all out. Third class, they were called vaginal mesh kits. These were large pieces of mesh that were placed through the vagina to fix prolapse. In some studies, these had a 50% complication rate, and the reason is because the thought is that you're introducing foreign material in an environment where bacteria naturally lives, and it was also being placed in a way where we could not take it out if we wanted to, right? So that is just rule of thumb. If you're going to get anything implanted, ask. Worst case, can you take it out? If they say no, consider other options before you up again. So the FDA pulled that off of market around 2019, so that should not be offered to you really anywhere, okay? So this is mid-urethral sling. I'm going back to that's my spiel about mesh. Mid-urethral sling, I like to do retropubic sling because it does have similar outcomes to the transobturator sling. The transobturator sling, though, sometimes can cause chronic nerve pain down the inner thigh, and I just didn't want to deal with that for my women, and so I prefer to do the retropubic sling. But they do work equally well. Polypropylene permanent mesh, basically treated plastic, okay? It's a quick procedure, 20 minutes, and it has about a 90% success rate. The longest study for this, I believe, is a 17-year study that showed a 95% success rate, meaning that at 17 years, 95% of women still had good bladder control with no complications. And then 2.5% risk. All right, this is our old school technique. We're going behind the urethra to support the urethra. This is now done robotically, and it takes about an hour and a half. It has a similar success rate to the other options, and so I still offer it. I was trained, I did my fellowship at Emory, where we had a very seasoned and old and lovely attending named Dr. Galloway. He was a urologist but had done trauma surgery. He was from Scotland, so that was a place where you could do whatever you wanted. So he was trauma surgeon, and then he was colorectal, and then he settled on urology. Anyway, wonderful surgical technique to get behind this space. There's a lot of vasculature in this space, so very few urogynes are actually trained to comfortably do this procedure. But it is a wonderful alternative for women who cannot use mesh or who are reluctant to use any other material in their body. All right. I always want to explain though to people that if for whatever reason if I need to get back into the space, it is another hour and a half surgery. All right. You guys still with me? We're almost through our slides here. Okay, so urge incontinence, conservative versus neuromodulation. Now, when I was in training, we used to have a very linear pathway when it came to treatment options, and in many ways, I think that's still a good form of treatment. I am a less is more person, so if there are ways for us to avoid invasive procedures, then I think that we should explore those if that suits you, or at least be aware that you have these non-surgical or non-invasive options. Today's American Urology Association guidelines state that you don't have to go through all of the non-invasive options. So, you know, if you are the person that's like, and some women are like this, I'm like, look, I just need surgery. I don't have time to putz around with things that I have to manage, you know. I think we will support you in that, but sometimes we will get insurance pushbacks. So that's my soapbox about that. So when we talk about conservative management for urgent continence, your thought is, how do I control the symptoms, right? So we talk about behavioral modifications, which is things that we're putting in our bodies that can irritate the bladder. It's about time voiding. It's about not drinking after, 2 to 3 hours prior to bedtime. Those are behavioral changes. Vaginal estrogen. So vaginal estrogen, a little bit about that, it's a very low dose. And when we look at your estradiol levels in your blood when you use vaginal estrogen, it's increasing it to what we call a postmenopausal level. Now that is different compared to hormone replacement, oral estrogen or patch estrogen. Those are going to increase your levels to a premenopausal level, and so they have a different risk profile, okay? Vaginal estrogen, we've done multiple studies. It is safe for women who have had estrogen receptor sensitive breast cancer. That is how low the dosing is. Of course, I always tell people to speak with their oncologist, but that is just to give you an idea of the safety panel, the safety profile for vaginal estrogen. So it is something that acts on the receptors in both the vagina and the bladder, basically to promote health so that bladder is not as sensitive as urine comes in. Pelvic floor physical therapy, we talked about that. And then medication. So last month we had Bailey Cranda talking to us about medication access. There are 2 categories of overactive bladder medication that we can choose from. One is anticholinergics and the other is beta-3 agonists. Beta-3 agonists are my favorite because they tend to have the least amount of complications, and that's Mirabetril and Gemtesa. And then our anticholinergics are really the old school medications. We have oxybutynin, which most people will hear about, and then we have a slew of others, and then we have trospium. Trospium, I would say, is probably our most forward-thinking anticholinergic. Little soapbox about that. Anticholinergics are found in different types of medicine for different parts of our body. Anticholinergics have also been shown to cross barrier into the brain and lead to early onset dementia. And so when we have women that have overactive bladder, that starts our battle with insurance for coverage. We do not want to prescribe anticholinergics if we can help it. And if we do, we want to prescribe our newer ones, our trospiums, Tovias, Enablex. These are medications that have been shown to not cross the barrier because the molecules are large enough to not have that same associated risk. All right. Neuromodulation. So now we're switching sides. So that's peripheral tibial nerve stimulation, Botox in the bladder, which sometimes I get chuckles about that, and then sacral neuromodulation. All right, so we went into conservative options already. So bladder irritants, time voiding. Let's see, did I skip over anything? We talked about side effects. Okay. So going into our neuromodulation options, we'll start with peripheral tibial nerve stimulation. Peripheral tibial nerve stimulation, I describe this as like acupuncture for the bladder. For some of our patients, they already have an acupuncturist that they go to regularly. I always encourage you to talk with them about your bladder dysfunction and see if they can offer you any interventions, especially if you're already going to be there every week or for ongoing sessions. But here, we place an acupuncture needle on your inner ankle and it sends pulses up to your bladder nerve root to kind of reset that bladder. If it works well, then you come in every 1 to 2 months for maintenance sessions. Okay. If you go more than 2 to 3 months, the efficacy will usually wear off. And I see about a 70% success rate, as in if 10 women tried it, 7 would be satisfied with the outcome. All right, so Botox. Botox is a natural occurring poison. Essentially, the way Botox works is it settles itself between where the nerve meets the muscle, and it blocks that nerve from firing to the muscle. Okay, so you have heard of Botox for the face. You may have heard it for migraines. It's actually used in almost anywhere in our body where we have muscles. We have found uses for it. Because as you can imagine, we can have spasms anywhere. And the same is true for the bladder. And so when we're using it in the bladder, we're injecting it in just below the surface of the bladder to help relax the tissue. And so it's really quick, 20-minute procedure, over 90% success rate, and it lasts for about 6 to 12 months at a time. There is a low chance that you're not going to be able to empty your bladder well afterwards. I would say in the last year or 2, we've had one patient that I can think of that couldn't empty to the point where we had to do some self-capping. And that is not permanent. As the Botox wears off, you're able to take control of your bladder again. And then the next time, if you come back for the next time, then we decrease the dosing. Okay, so it's adjustable. The one thing we do look out for is risk of bladder infections. Okay.
Can I ask you a question?
Absolutely.
I see is that a needle going into
Yes.
through the wall, the abdominal wall?
No, so I'm using a cystoscope through the bladder opening here, and then I introduce the needle through the camera, and then put the injection in. Cool. Good question. Okay, so this is sacral neuromodulation. Sacral neuromodulation is a device implant. It's sometimes called like a pacemaker for the bladder. And this device is ideally implanted at the S3 nerve root, okay? And it sends these pulses to that nerve root to reset the bladder and the bowels. So I say reset because scientifically we don't know how to explain how it works. But similar to PTNS or acupuncture, that pulsing sensation tends to realign the nerves for proper function. Sacral neuromodulation has come a long way. It used to only be done, I believe, by like neurosurgeons, right? They had to do a full cut down, open, see the nerve, place it. And now today we can use a needle with or without X-ray guidance in order to find that nerve root. And if we do the first phase, which takes maybe 30 minutes to successfully find it, and if you love it, then we also implant the battery 2 weeks later. Okay, and that battery is little. I describe it as like three quarters stacked, and it just sits in your butt cheek. We used to have a battery that needed to be replaced every 5 years. You had to charge it every night. Now the battery is 10 to 20 years without having to be recharged at all. It just set and go. So let's see. It treats, on paper, it'll treat urinary retention, so inability to empty. It also treats urinary incontinence, which is, leakage from urgency, so not stress, but urgency. And then it'll also treat fecal incontinence, ideally from urgency, but we also see improvement from women that have old traumatic sphincter injuries, can also have significant improvement. Anecdotally, it'll also treat constipation, pelvic floor spasms, it can treat pelvic pain. And so those are kind of off-label uses, but we've seen great results with those too. Now, insurance wants at least a 50% success rate. I aim for 85% success rate because it is a device that you're going to use long-term. And so once we go through phase 1, we go through that conversation of whether or not you're happy and want to move forward. Biggest risk with this is lead migration. So if you are someone that has a lot of falls, it may not be a good option for you. And I did have a patient in fellowship who had a great lead placement, but then when she got pregnant, as soon as her muscles relaxed, the lead slipped out of place. So we just had to replace it after she delivered. So that is another way it can migrate. All right, so that is my spiel on bladder leakage. And we'll start with questions for anyone that's here in the room, and while we're looking at the chat for any possible questions.
So is your presentation available?
I can make it available, absolutely. If you would like one, let me know, and we can email it to you.
Okay.
All right.
Sacral neuromodulation. Exonics is the brand name or something?
Yes.
You
Excellent.
mentioned several issues it could treat.
Yes.
So could you put it in and have it treat all of those
Yes.
with one
With one
device?
device. Mhm.
Okay.
Axonics is a brand recently bought by Boston Scientific. The other competitor is InterStim. InterStim makes heart pacemakers, and in all transparency, the thing about devices is the long-term management. So knowing that this patient's not going to get lost in the shuffle, and Axonics has wonderful customer care. So that's why I choose them over InterStim. Products are very similar, but what good is a product if you can't manage it long term? Yeah.
Okay, Annette is asking what the recovery time is
Okay. For which procedure?
for Annette. Did you have a specific procedure? She didn't put it in the chat.
Okay.
Annette says mesh.
Okay, so for the mid-urethral sling, great question. I like to have a 6-week recovery, and here's why. Those slings are not attached to anything. And so we are really relying on your body scarring around the tissue. So when we do too much too soon, the mesh will slip out of place, and then we either get inability to empty or it doesn't work as well. So the first 2 weeks is, definitely up on your feet 3 times a day, 15 minutes, no excessive bending, 10-pound weight limit. When we get to 2 weeks, we increase that to 30 minutes, 3 times a day. A lot of patients will go back to work a little bit after 2 weeks if they have a job where they can kind of sit and elevate their feet. And then sometimes we'll cheat, and around 4 weeks you can travel and, kind of resume things. But I think the most critical time that I've seen is that first 3 to 4 weeks of placement. Ideally 6 weeks is good.
Okay.
Alrighty.
Cheyenne would like to unmute and ask a site challenged question, I think,
Yeah,
is what
go
she's alluding to.
Go ahead, Cheyenne.
Go ahead.
You.
Oh, hold on 1 second, Cheyenne. Go ahead.
Okay, so I typed in the text, the chat.
Okay.
I had a mesh put in 2006, and we had discussed at one time removing it.
Mhm.
So the procedure you're talking about now would be an improvement, correct?
The procedure I'm talking about now would be an improvement. I have to remember. Do you remember what it was placed for?
For stress, but I
Yeah.
have urge incontinence.
Yeah, I think you had some issues with your mesh, and so we needed to remove it for that purpose. Let's say you have a sling though, as a rule, if you have a sling for mesh, and let's say it doesn't work, and I'm like, you could repeat it. It is okay to repeat it and place 2 slings and have 2 slings in there. It's actually okay. You don't
Great.
have to
And
take out
if
the
you
first
have a
one.
history of, I'm having stones, either bladder stones because I don't have a gallbladder, but I've been passing stones, and I've had some terrible UTIs and frequent UTIs. That would preclude me from having surgeries, or do I stick with the behavior modification that I've been doing for the past 20 years?
I think I'm a big proponent of trying to get those stones resolved. So I'll usually refer you to urology so that they can figure out, first remove the stones. A lot of times we try to involve nephrology to figure out why you're making the stones. And then also, like, if you have mesh, Cheyenne, we want to make sure that that stone is not from the mesh, right? Mesh can erode and cause stones in the bladder. So as long as we're checking all those boxes, then we go down the road of how do we treat your leakage. I don't think that stones limits you from interventions for leakage though.
I've been treated with pelvic floor, and my technician retired. I'm older. For some of you, I've been doing this for over 20 years. So I've been treated by Dr. Abanulo for a rectal seal back during the pandemic and for prolapse. And so right now I'm having to concentrate on my sight and other issues, but that's something that I'd like to see you about next year maybe.
Yeah. You're still on my roster. We have to put a pin in your care, so I understand. Let me know when you're ready. Thank you.
Yeah, I saw you several years ago and you put me on the Metric.
Yes.
And it's not working.
Okay.
I still have
We need a time.
bad urge.
Was
So
it years
I'll
ago?
come and see you.
Gosh,
Yeah, it was a few years ago.
You look. I feel like I just saw you, but maybe not. You do look familiar when you came in.
You do?
Yeah.
I just cut my hair. I had longer hair. Anyway,
No. Let's make an
that was a
appointment.
few years ago.
Question?
Yeah. Let's make an appointment.
So I should make an appointment.
Hold on one second, Terry.
And we can chat a little bit after this too.
Okay.
See your doses. Any other questions?
Question?
Yep, Terry's got one.
Can the mesh cause stones, bladder stones?
Yes, it can if it erodes into the bladder.
One that eroded, that moved. But, and I've had so many UTI infections, like every 2 months. Can the stones cause the UTI infection?
Yes, stones can cause UTIs. They basically create a home for the bacteria. And so the bacteria will treat it like a nidus. And they'll just
How do you find out if you have stones in your bladder?
So we will do a urine test and we look for crystals. So calcium oxalate is a specific crystal. Almost always is calcium oxalate, but you might also have calcium phosphate. There's some other crystals that are not related to stones. So you get that urine sample. If I see blood or if I see crystals and you've got these recurring bladder infections, then we need to image your urinary tract system.
So you could do that at my next appointment, right?
Yes, I can.
Okay, thank you.
Yes, thank you.
So do you have Zoom for all your presentations?
Yes, we do have the Zoom link.
I didn't know that.
Okay, well, I'm glad you didn't know because now you're here.
I was traveling in the dark, that's
No,
right, just now.
Okay, guys, thank you so much for tuning in. Thank you, ladies, for coming. I
Thank you.
appreciate it. So next month is our talk with Jessica Dorrington. We have one more question. She'll be doing a talk on pelvic floor therapy. And we have one more question here.
Annette just asked, is the imaging part of the first appointment? And I kind of said depends.
Yeah.
Because it just depends on what we find.
So it depends on what we find. But usually your first appointment, we're just creating a plan and then we kind of take off from there. Your first appointment here is like an hour long. I mean, we go into everything and then create a very extensive treatment plan for you if needed. But we do try to cover all bases from jump. Excellent. All right, I think that's it. If you have additional questions or maybe you don't want to ask questions in the chat, completely fine. You can send an email to learnmore@femmeflor.com and we will get back to you.